No, please, you are ready.
So let's start. So we are. It's left with the. It's left with the treatment or management. Management of the IBD. So it's left with the management. Please, are you ready?
Yes,
Let's
please.
go.
Mm-hmm.
Yeah, please.
Matthias. It's Matthias alone.
Yes, please, sir.
Have you informed the rest?
Yes, please.
Okay. What about Melvin? Is Melvin around? Kumasi people, are they aware? Face to face, guys, are they aware?
Yes, please, sir.
Yes, sir.
Okay, so management. I told you yesterday that IBD is a chronic disease. So two things. To manage it, it becomes like hypertension, chronic. So there could be remission and there could be relapse. These two words, okay. Remission comes and there could be relapse. And because of that, because of the chronicity, we say that there is no cure. Same as diabetes, the same as hypertension. People are claiming those who sell herbal preparations are claiming their medication that could cure diabetes. Cure. So IBD is a chronic and cannot be cured. IBD cannot be cured. And therefore, So three things are done. So you think about nutritional supplements, you think about medication, and you also think about at times surgery comes in. Surgery. So nutritional supplements, drugs, medications, pharmacological. Non-pharmacologically, we think about nutritional supplements. And at times surgery comes in. So IBD, because of this condition IBD, there could be functional or structural damage to the GN. This, if we have inflammation affecting the small intestine, it should be a functional damage. There could also be a structural damage. So anywhere that this inflammation or this IBD occur, it will cause a functional damage, to cause a structural damage. And this can lead to malabsorption. This can lead to malabsorption. If there's malabsorption, the patient can be malnourished. And this can lead to nutritional deficiency. That is why nutritional supplements are very important here. I'm saying anywhere that we have this IBD, there's a functional or structural there could be a damage. And this could lead to malabsorption. This could lead to malabsorption. And because of that, there's a risk of the patient becoming malnourished. There will be malabsorption because of the structural damage and the functional damage. There could be dates, malabsorption. And there's a risk of the patient becoming malnourished. And the patient can develop, because the patient is malnourished, the patient can develop nutritional deficiencies. And therefore, you should support the management with nutritional supplement. You should support the management. It becomes an adjunctive treatment. Adjunctive treatment. Thinking about giving the patient vitamins, giving the patient, at times there's bleeding, which can lead to iron deficiency. So you think about giving the patient these supplements. And another thing that you should also be careful is that when you are giving that, think about giving diets which are low in fiber, low fiber diets. Why is it important to give low fiber diets? Who can tell me? Why is it important to give a low fiber diet? Why is it important to give low fiber diet to the patient? Can you hear me?
Hello, Doc.
Mhm.
Yeah, I'm looking at the fact that maybe when those diet to cause the person to go to the loo more frequently. So to avoid those temptations.
Again.
Look, I'm looking at it from the fact that when we take him, we know that fiber diet will enhance one isn't about more frequently or easily, which is good although, but maybe for the pain the person is going through, got the malfunctioning, the person will have difficulties going through the washroom or the loo. So we should reduce it.
Come again for the last time. It's a straightforward thing. So come again for the last time.
So please, I'm saying, I'm looking at it from the point of view that the person who want to visit the low frequency if he's taking low fiber diet to avoid that because of the person's condition, you want to avoid it.
So the condition, what is in the condition that would call for low fiber diet?
The condition itself causes diarrhea.
This is the way I want you to answer it. Straightforward to the point. The condition will cause diarrhea. And so, continue.
So fiber diet also encourages loose too. Therefore, it will not be good for the condition.
It's not be good for the condition. Good. Please learn to go straight to the point. In your answering of the questions. You know, IBD, we're talking about ulcerative colitis. We are even talking about bloody diarrhea. And when you're talking about Crohn's, you're also talking about diarrhea. There could be bloody diarrhea in where? In Crohn's, depending upon where we have the inflammation. And normally we use the word variable. The presentation becomes variable in Crohn's because of where the inflammation could be found. But in ulcerative colitis, is located and restricted to the colon. Therefore, we can go straight away and say that the bloody diarrhea. So diarrhea is there. High fiber diets would also enhance this. Also worsen the diarrhea. So we advise that patients should avoid that. The patient also requires low lactose diet. Low lactose diet. So which diet contains high lactose and which diet contains low lactose? Mention one or two diets with low lactose. Diets with high lactose. Patients should be encouraged to take low lactose diet. Do you get what I'm saying? So which diets? Who is dietitian among us? The ladies, you are not talking. You are the dietitian. Ladies, are you there?
Mamiaba.
Mamiaba, I'm waiting for you.
Dr. Attakorah, a low lactose diet will be one that does not contain any dairy. So those milk, yogurt, cheese.
There was a Mamiaba example, and let's go. This is the way you answer questions. I hate this. We are asking examples of low lactose diet, and you are coming to tell me low lactose diet. Hey, so what is that low lactose diet?
Almond milk.
It will not miss you.
His Higa can help us.
Stop this kind of your answers. Give me examples of the low lactose diet. Then you say that low lactose diet contains low. What is this? Mamiaba.
Dog cheese.
I'm going to. So which diet contains high lactose? Common diets that we have. Which diet or which product contains high lactose? Common. Hmm? Okay, so find
Milk.
common milk,
Animal-based milk.
Yogurt.
yogurt. These are the common. Huh? Nuts are low. We have dry beans. These are low in. So when the references are saying we should recommend low lactose, that we should understand why they are saying that. And we should also understand why they are saying we should do a low fiber diet. And at times, the total parenteral nutrition, TPN, is recommended when a patient comes with this because of the malabsorption. The total parenteral nutrition at times are needed for the patients. Okay, so we said that nutritional support, there'll be nutritional support, then the medications. So the medications or the drugs, medication. Then we'll be talking about pharmacological. So in managing IBD, what to be your goal, what to be your aim in managing ABD? So you think about treating the acute attack. There will be relapse, that's acute. Think about treating the acute attacks. And you think about inducing and maintaining remission. So treating it, we want to ensure that the patient gets remission and you maintain the remission. That is that. And giving the medication, think about giving a medication that will limit drug toxicity. These drugs are toxic. But if you're recommending methotrexate, these drugs are sulfasalazine. So in your selection, if you think about medication that could limit the drug toxicity. So you also look at modifying the disease pattern. You want to modify it, ensure that you don't, the inflammation does not spread, modify. You want to avoid complications. If you think about managing such that the patient will not be tipped into any of the complications that were mentioned. So at times certain medications are used, but they are not. It's offline, online things, and they are used. So the mainstay medications that are considered in IBD, we have the steroids, the corticosteroids. So we have the steroids one, the steroids. We have the amino salicylate, amino. So A, H, A. So amino salicylates. And the last group is the immunosuppressant. So immunosuppressant. So these are the mainstay. You think about giving AHC, you think about giving steroids, and you think about giving an immunosuppressant. There could be, at times, you consider antibiotics, such as metronidazole is also helpful. It's also helpful. So metronidazole, which is antibiotic, is also helpful. And in managing this, depending upon the location of the inflammation, you could be giving suppositories, you could be giving NMX, foam NMX, you have liquid NMX. So depending upon the location, you could be giving that. So if the disease is confined to the anus, confined to the rectum, or is left-sided of the colon, then we could be giving this rectal administration, be giving these topical preparation, could be given rectally, administration rectally. And these are topical preparation. So depending, these ASA, they have topical preparation. Steroids, they have topical preparation. It can be given depending upon where it is. So that is that. So example, if you have proctitis, so what is proctitis? So if you have proctitis, if you have sigmoid, normally proctitis or sigmoid, the length is not so much, to be around 15 to 20 centimeters. The length is not so much. In these instances, you can give this topical preparation, that is rectal administration. So you can give these home elements to manage it. When it's into the colon a bit, like extensive colitis, left-sided, it is about 30 to 60 centimeters. You can consider liquid enemies. So we have foam enemies for when the inflammation is within certain length, like 15 to 20 centimeters. If it's about 30 to 60, when you consider left-sided colitis or extensive colitis, then you can consider the liquid, and push the liquid enemies there because it's deep. So that's for the introduction. So when you talk about the medication, let's see, ASA, amino salicylate. So AHA, amino salicylate. So example of these amino salicylates are sulfasalazine, lyserlaxine, or sarlaxine, and sarlaxine. Let me ask this. I know you have come across these medications. What is the difference between mesalazine and osalazine? What is the difference between osalazine and besalazine? What is the difference between these medication? Amino salicylates. Examples of amino salicylates. We have sulfasalazine. We have sulfasalazine. We have mesasalazine. We have osalazine. We have salazine. So, what are these medications? What are these medications? What is the difference between mesalazine and osalazine or salazine? Can you hear me? Am I muted?
No, sir, we can hear you.
We want to hear you too, so. Or you are checking it?
Please, the osalazine, sulfasalazine, they are prodrugs that become mesalazine.
Mesalazine. I'm listening. So these are the medication under amino salicylates. Amino salicylates. These are so the active multi or the active drug under amino salicylates is the mesalazine. So we have mesalazine. So we have osalazine. Osalazine is a dimer. Osalazine. So when we have this dimer of mesalazine, then you'll be getting osalazine. So we have dimer of mesalazine, then you'll be getting osalazine. The salazine is a pro-drug. This is a pro-drug of amino salicylates. This is a pro-drug for amino salicylates. So the active, which is a mesalazine, is also called 5-amino salicylic acid. 5-amino salicylic acid. 5-amino salicylic acid, and it's the mesalazine. So we have sulfasalazine, and sulfasalazine is the combination. So sulfasalazine is the combination of 5-amino salicylic acid plus sulfapyridine. So we have this plus sulfapyridine. So sulfasalazine is a combination of 5-amino salicylic acid plus sulfapyridine. These combination will give us sulfasalazine. And we have mesasalazine. Mesasalazine is the same as 5-amino salicylic acid. We have osalazine. And I'm saying that osalazine is the dimer. Osalazine is the dimer of the 5-amino salicylic acid. It's the dimer of this. And normally this diamond, there will be a cleavage. When it gets into the site, there will be a cleavage. There will be a cleavage. So bisalazite is also a prodrug. It's also a prodrug that will release these 5 amino salicylic acid. Please, is it clear?
So please, I didn't get the last part.
What is the last thing I said?
I got to up to where you said the oxalazine is the dimer of mesalazine.
Okay, so I've said a lot, I don't know. So ASA. So amino salicylates. So amino salicylates. Amino salicylates. I am saying that amino salicylates, these are the medications that are considered under amino salicylates. So the common ones are these: sulfasalazine. We have sulfasalazine. We have mesalazine. And I'm saying that mesalazine is the same as the 5-amino salicylic acid. 5-amino salicylic acid. So we call it 5-ASA. 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 So we also have oxalazine. Oxalazine. So I am saying that this is a combination of 5. Sulfasalazine is 5-ASA plus sulfapyridine. So it means that sulfasalazine is mesalazine plus sulfapyridine. Oxalazine is a dimer. It's a dimer. It's a dimer of 5-ASA. And basalazide. This is a prodrug. This is a prodrug. So that will be metabolized to 5-ASA. Any question? Any question? The one who said,
So please, I'm fine. Thank you very much.
okay, so the commonest one is this, sulfasalazine. That is the common. That is the common. So let's move on. So let's talk about a little about, okay, these medications, you should know the general common side effect of these medications. And some are so specific. So common side effect of these medications, you should know. Something like diarrhea, something like nausea, vomiting, abdominal pain. These are common side effects generally of this. This class of medication, you could have the oral and you could also have the rectal preparations, oral preparation and the rectal preparations. So I was saying that the commonest that we have in Ghana is sulfasalazine. Sulfasalazine is the commonest that we have in Ghana, sulfasalazine. So I say that sulfasalazine, that's the way the references put it. So sulfasalazine is the combination of 5-ASA plus sulfapyridine. So we say that sulfasalazine consists of sulfapyridine diazotized. This is the word that they use. It's not, they don't say it's. We say that sulfapyridine, sulfasalazine consists of sulfapyridine diazotized to mesalazine. That is combination, but they use the word di. So the chemistry people would explain to us diazotized. So sulfapyridine is diazotized to the mesalazine, which is a 5-amino. This pyridine is diazotized to this. And so when they get into the colon, there will be a breakdown. This sulfapyridine is just a carrier. It's just carrying this to the site. The mesalazine, which is the active, to the site. So sulfapyridine is just a carrier. The reason why this drug does so much side effect is that the sulfasalazine, the mesalazine will give you side effect. And the carrier, sulfapyridine, will also be giving you side effect. So this product will give more side effect than giving patient only mesalazine. Because only mesalazine will not give you more side effects like sulfasalazine. Sulfasalazine comes with mesalazine plus sulfapyridine. And sulfapyridine is just a carrier. It's not going to do anything. It's not going to contribute anything apart from carrying the mesalazine or 5-ASA to the site. It will not do anything. And therefore, when it gets into the site, there's a breakdown. There's a breakdown by a bacteria called azoreductase. Azoreductase. This enzyme will break this. When they get to the site, will break this. Then this will get into the system. This will get into the system, will reabsorb into the system. Then it will be excreted by the kidneys. this. So this, because it will be absorbed into the system, this will be also be giving you its side effects. And it's sulfur base, therefore will be giving you side effect of that. So there's this azoreductate enzyme, bacterial enzyme, that will cause cleavage, to cause a cleavage. And this will be absorbed. And ASA, there's small absorption of ASA, partially absorbed. And this ASA is also metabolized by the liver and also excreted by the kidneys. So that's sulfasalazine. And normally, patient on sulfasalazine, one thing that the patient can experience that you need to tell the patient is that the body fluids, when the patient is on sulfasalazine, the body fluids will tend to be yellow. So there will be a yellow coloration of the body fluid. And this is something you need to tell the patient. Certain medication will give you vision, yellow discoloration, or you'll be seeing everything yellow. Certain medication can do that. This one is not giving you that vision. This one is turning the body fluids to be yellow. So you tell the patient that this could be the outcome when he's on these medications. And so this drug is common in Ghana. It's common in Ghana. So when a patient cannot tolerate this, the best thing is that, personally, I like that you start the patient on mesalazine. Start the patient on mesalazine because it would avoid the side effects. So you avoid all these side effects of PVD. And about 80% of the patient tolerate mesalazine. They tolerate mesalazine. So mesalazine should be Safu. Can you mute your Safu? Could you Safu? Who signs it up? Alhassan. Alhassan, is there any issue?
No, sir, this was a mistake.
Okay. So 5-ASA should be considered, which is mesalazine, to be considered for the patient. And for this, please, find out. Who can tell me? Normally, I don't ask about these doses of sulfasalazine. Few side effects of this, few side effects of mesalazine, possibly dose. Let's quickly check the dose. Few side effects of these medications. So these medications are used. And note this. Mesalazine preparations are licensed for use. Mesalazine preparation 5ASC are licensed. Are licensed for use. License for use, and there are certain preparation for 5ASC, which are also licensed for Crohn's disease. So, which are also licensed for Crohn's. Who can tell me one preparation of mesalazine, which is licensed? All preparation for mesalazine are licensed for use, but not all are licensed for Crohn's disease. Who can tell me one preparation which is licensed for Crohn's disease? One preparation which are licensed for Crohn's disease. So we have Attakorah. We have Attakorah MR. Attakorah MR are licensed. It's a mesalazine preparation, and they are licensed for Crohn's. So these are one of the class of medication that could be considered in managing IBD. One of the class managing IBD. Okay, so another class is the immunosuppressant. So immunosuppressant. So these are also a class of medication that are considered. Examples of these class are azathioprine. We have sosmecaptopirin. Sosmecaptopirin, methotrexate. Please hold on for me. Hold on. Hello. Hello.
Yeah, hello, doc.
Yellow.
Okay, so these are also a class of medication. We have these medication. So methotrexate is also here. Methotrexate is also here. So we have trexate is also here. We have cyclosporin. We have a lot of medication, but we'll be tapping the common ones. One medication which is not common that we use, mycophenolate. 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 So these are class of medications that are used. Let me ask you questions here. What is the difference between azathioprine and mercaptopurine? These are used. So they will modulate the immune systems, the cytokines. They will try to modulate these cytokines. What is the difference between azathioprine and cis-mercaptopurine? Who can tell me?
Hello.
Hi.
Please, azathioprine is metabolized to cis-mercaptopurine.
So which organ is responsible for that? Which organ is responsible for these conversion?
The liver.
So the liver is responsible for this. So this is metabolized to this. Last time, I said those who have the past questions, I said question on IBD. And I was asking about IBD patients. There's a question about IBD. Don't know whether you have that past question. You have past question from Adam and Eve time to this time. So that same patient, IBD patient, also had gout. Same IBD patient also had gout. So I'll ask this question. The use of azathioprine. The use of azathioprine and allopurinol. The use of these two medications. Who can tell me? Who can comment on the use of these two medications? Who can tell me the use of these two medications? When we are using these two medications together, who can tell me?
Hello, Doc.
Hello?
So, the same enzyme in the liver metabolizes the two drugs. And therefore, when you use the two drugs together, there will be more of the drug in the system because the enzyme will metabolize one whilst the other will be free in the system. So it will be more in the system.
I don't like the way you are answering the question. You are not saying anything. Please, I don't like your question. The way you answer questions, please. You have generalized the whole thing and you are talking about it. I've mentioned 2 medications. You haven't mentioned anyone. You are talking about the. Huh?
Hello, Doc.
Hello.
So,
Precious Broby. Who is that?
Please, I'm the one.
Your hand is up.
I wanted to answer the question, please.
Okay, somebody's on. Then let the person try and see.
Okay.
Somebody was talking.
Yes, please. So, allopurinol is a xanthine oxidase inhibitor. And this xanthine oxidase is the same enzyme that metabolizes azathioprine. So if you inhibit xanthine oxidase, you are going to increase the serum concentration of azathioprine. And as such, you are going to be exposed to more of the toxicity. So giving them together, you can either reduce the dose of azathioprine or change to an alternative.
Okay, so that is that. Precious, let him hear from you.
Sir, please, exactly what you said.
Tell me.
Allopurinol is a xanthine oxidase inhibitor, and xanthine oxidase is the xanthine oxidase is responsible for the breakdown of the azathioprine. So it will cause the accumulation of the azathioprine and prime, and there will be an increase in the side effects or an accumulation in the system, so that the side effects will be. Please, exactly what you said.
And so, what will be, as a pharmacist, what will be your recommendation?
So, Doc, as I stated, you can either reduce the dose of azathioprine or we can change to an alternative that can help us achieve the same job. So if it's immunosuppression we want, we can change to maybe methotrexate and then monitor for presence of maybe stomatitis, or can supplement with also folic acid so that we prevent folic acid deficiency or folate deficiency.
Okay, so you are right.
Hello, sir. Hello, sir.
Hello.
Sir, please, can Uncle Stephen take what he said again?
Uncle Steve.
Hello, Doc.
I didn't know you are Uncle Steve.
Oh, Doc. I'm not uncle.
Oh, but you heard Uncle Steve. Yes, can you?
So please, I was saying that for intervention by a pharmacist, we don't want the toxicities of azathioprine to be experienced by the patient. So it's either we reduce the dose.
How are your people laughing?
Doc, I don't know.
Ask them. Ask Frida Boateng and Co. Ask them.
Yes, sir.
Alberta, why? Ask them, please, for me.
Yes, please, I will. So please, it's either we reduce the dose of the azathioprine or we change to an alternative immunosuppressant, which methotrexate can be an option. Then monitor the patient of side effects of methotrexate, and then we also give folate to prevent folate deficiency.
Thank you, Uncle Steve.
Somebody also came in. So, are you okay?
Yes, please. Thank you.
Okay. So normally these medications, we consider the glucocorticoids. We consider the glucocorticoids. So we will not be considering the glucocorticoids before we use these immunosuppressants. So when a patient, can you tell me one or two conditions where just one or two conditions which will call for the use of these azathioprine, methotrexate, and co. Can you tell me one or two conditions that will call for this? The use of this.
Rheumatoid arthritis.
I am saying that we should, you know what? The best thing is that you can consider ASA, you can consider the steroids, which is the glucocorticoids. Then this will be the last option. And I'm saying that which conditions will call for this, the azathioprine group, instead of glucocorticoid.
Please, can you come again?
I'm saying that tell me one or two conditions that will call for this azathioprine methotrexate. Normally, it's considered as a third option. So you consider ASA, you consider the steroids, and these are considered. So when you are considering this as a second option, immunosuppressants as a second option, then there could be one or two conditions that will call for this to be the second option. Who can tell me? You get my question. Or it's not clear?
It's usually when the patient has a comorbid condition of gout. That's when you can't consider that.
Who can tell me? Do it better for me. So normally you do ASA and you would consider glucocorticoids. So if you put your patient on glucocorticoids and you take your patient off from glucocorticoids, when you take a patient off from glucocorticoids, and all the time there's a relapse when you take your patient from glucocorticoids, then you need to consider the use of what? The use of the immunosuppressants. So you put your patient on steroids. Anytime you withdraw the steroids, there's a relapse. Anytime you withdraw, there's a relapse. Then you can put your patient on immunosuppressants. Or another condition is that when you have situation like for a year, you have to do two steroid courses. So if a patient requires 2 or more steroid courses in a year, so in a year, if you are doing, assuming you are doing, say, and for example, you are doing 1 month as a course, assuming, and for a year you are doing more than 2, When you are doing more than 2 per year, then you need to think about going into this. So another condition, they have a lot of conditions whereby you could bring this as a second option. But I'm just mentioning to you. For a year, if you are doing more than two courses, so 2 or more courses of steroids, or the moment you withdraw the steroid, the moment you withdraw it, there's a relapse. When we have this situation, it means that the patient will have to be on it all the time, because the moment you withdraw it, there's a relapse. When you have this situation, then you can change this to the immunosuppressant. Because when you put your patient on azathioprine, there's one advantage. When you put your patient on azathioprine, who can tell me that cis-mercaptopurine azathioprine, when you put your patient on it, what is the linkage between steroids and cis-mercaptopurine or azathioprine? Who can tell me the linkage? What is the linkage between spironolactone and potassium? What is the linkage?
It is potassium sparing.
It is potassium sparing. What is the linkage between azathioprine or
Steroid.
come again?
Steroid spray.
It's also steroid sparing. So note this. Note this. So when you put your patient on these medication, immunosuppressants, when you put your patient on these medication, make sure you should put your patient on it up to 5 years. The patient should be on it up to 5 years. So when you start these immunosuppressants and you withdraw, early withdrawal would also increase the rate of what? The relapse. Early withdrawal will also increase the risk of what? The risk of relapse. Early withdrawal. So normally you try to put your patient maybe more than 5 years. Less than that, there could be a increase in the relapse when a patient is on these medications. Methotrexate, one of the commonest methotrexate. Who can tell? Because it also use it in oncology. Who can tell me how do you get people? And what will you do when a patient is on methotrexate?
This you add folinic acid.
Hello? Adam, I'm listening.
Please, I was saying you add folinic acid.
You add folinic acid. So how do you add it to it?
Okay, so we have various regimens of methotrexate, but usually from what I know, we alternate the methotrexate with the folinic acid. So if patients receive, especially for those who are on the intensive dosing, if they are taking methotrexate today, the next day they are giving the folinic acid, and so we alternate between them so that it reduces the toxicity of methotrexate.
So let me ask you, push you more on this. What is the difference between folinic acid and folic acid? Or folic?
So folinic acid is more active, the active form of the folate.
So when you are giving folate with methotrexate, what should you do?
So I know methotrexate depletes folate and by its mechanism of action, and so usually you want to alternate the days or space out the duration between the folinic acid and then the methotrexate.
So folinic, I have folinic acid, I have folic acid. How should I go about it? I have the two. How do I go about it?
You give one or the other.
Mhm. You don't get what I'm saying.
Yeah.
You get what I'm saying?
No, please.
Will it be the same? Now I have the active, the folinic acid. I have the folic acid. Folic acid is not the active. How am I going to, would it be the same way of advising the patient or there will be different? You get what I'm saying, or you don't get it?
No, please.
What I'm saying is that we have folinic acid. We have these two medications. Do you know that?
Yes, please.
We have folinic acid and we have folic acid or folic. I'm asking you, if a patient comes to you with these two medications and is taking methotrexate, how are you going to? Will it be the same advice or you are going to, because it's a different product, are you going to say it's the same? The way you are going to tell the patient is the same advice. Do you get me, class?
Yeah.
Adam,
Yes. So we tell the patient that the folinic acid is the active form, and the administration, the drug is a little different from the folic acid that they usually take.
so let me, I just want, I don't know if I am not putting the question well. Adam, I said you have these two products. You have folinic acid and you have folic acid. I'm asking you, if a patient comes and the patient is being given methotrexate, for these products, are you going to give the same advice or there will be differences in advice in terms of giving the two? You get it? Or still it's not clear?
So please, you can take the folinic acid alongside the methotrexate because the methotrexate will not impede the metabolism of the folinic acid.
I want Adam.
Please, I get it. I know. I get it now. So, the methotrexate won't inhibit the activation of folinic acid, but will affect the activation of folic acid. So, folinic acid is more specific for the administration with methotrexate, but folic acid can be done in like a supplement for any other condition.
So still back to my question. The lady your mate was trying to do it work for you. Back to my question. I'm saying that these two preparations, that is why I was asking you, these two preparations, folinic acid and folic acid, you are giving it to the patient. What would be your advice in this preparation? You are giving it with methotrexate. What would be your advice? Would it be the same advice like take this?
No. So with the folic acid, you advise the patient to take it before
And then somebody
taking
is
the
with you and he's also. So there's an echo.
I'm in my room alone.
You can be in your room with 10 people. But if you're in your room alone, there won't be any echo. I'm in my office alone. There's no echo. You are in your room with your girlfriend. That is why there's echo. Adam, I will tell Uncle Steve. Uncle Steve, are you around?
Yes, sir, I'm here.
Good. Adam, go on. Class, do you understand?
Yeah, please. So I was saying that for the folic acid, because it requires the activation, you usually advise your patient to do it before taking the methotrexate so that the methotrexate doesn't affect the activation. But with the folinic acid, that advice will not be important since it is already active. And so they can take it after taking methotrexate.
So folinic acid could be given with methotrexate. But folic acid could be done a day after. Normally, you don't do the two together.
Yes.
Adam, if I can see your room, I'll be happy. Because a lot of noise are coming from the echoes. Adam, you are the people who are giving the link to others, your colleagues. So they join you in your room. Class, do you understand? Am I muted? Hey, do you understand this?
Yes, sir.
Hey, God, have mercy. Okay, so we use methotrexate for Crohn's disease to induce and maintain remission. We use that. Normally, you can give 15 to 25 milligram once a day. So when you give it, and the following day you can give your folic acid or folate. But when you have the active product like folinic acid, there won't be any activation. Therefore, you can combine it with that. So methotrexate are commonly used. So find out few side effects of these medications. Okay, so there's also, I'll do the glucocorticoids. There's also another class of medication. So biological agents. We have the biological agent. So we have cytokine modulators, biological agents. These biological agents are also useful. So these biological agents inhibit the activity of these pro-inflammatory cytokines. And some of the cytokines are T and F. These cytokines tend to damage the cell lining in the gut. And this will cause pain. When they are causing destruction, cause pain. It will cause cramps. So we have these cytokines modulators. We term it as biological agent. Cytokines modulators. And they would affect the functional activity of the pro-inflammatory cytokines. Example is that TNF, interleukins, and the rest. So these interleukins, they will damage. When you allow them in there, they will damage the cell linings. They will damage the cell lining. Examples of, who can tell me one or two examples of these biological agents? Who can tell me one or two?
Infliximab.
So infliximab. Nowadays, the medication coming is difficult to pronounce. So we have infliximab, and we also have what? Adalimumab. These are cytokine modulators. And it's now, I don't know whether it's common in a part of the world. I don't know whether it's common. Because of these cytokine modulators, some are common now because of this. So we could also consider this in our treatment. We talked about other antibiotics. You can use metronidazole. In these cases, you can use metronidazole. You can also use because of the diarrhea. You could also consider codeine, loperamide. You can also consider codeine preparation. You can also consider loperamide because of the diarrhea. So these are other medications that could be added. The last class that are considered are these steroids, corticosteroids. Corticosteroids are considered in IBD very much. Adam, is your hands up?
Yeah. Please, I want to ask about the hydrochloroquine for the cytokine reduction. Is it possible to use it?
For 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 IBD, this is considered more in arthritis, but for IBD, the use of this is I don't know. Mostly they consider the other as azathioprine, methotrexate, cyclosporin, but I haven't really seen this being used in IBD. There are certain medication that could be used that could be offline, but in 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 cases like arthritis, they can consider the medication, but in IBD, I haven't seen them considering that. We had one case at Confanoche. Few cases that I've seen, you were not considering those medications. Normally, the medication, the first medication that they would do would be more of the mesalazine plus the glucocorticoids. The mesalazine and the glucocorticoids. So it's not, I haven't seen any of them considering that.
Yes, please.
Okay, so the last class, which is very important because it's inflammation. Why do you think that it's the best to use glucocorticoids? Why is it the best to consider glucocorticoids? If I tell you to give me 2 reasons why glucocorticoids could be considered, what would be your answer?
Because glucocorticoids have efficacy on multiple mediators neurotransmitters that mediate inflammation.
Simple answers. Glucocorticoids.
Doc,
Mm-hmm.
Doc, please, IBD is an inflammatory condition and glucocorticoids are anti-inflammatory. And also they can induce remission in the shortest possible time.
You could, in case of that, you could use budesonide. Budesonide could also be considered. And budesonide will do that perfectly. But I'm just asking you, this is a simple question. You are right by saying it has anti-inflammatory activity. What is the next? Why the glucocorticoid? You could have considered any other. Glucocorticoids are not only anti-inflammatory agents that we have, but why is it the best to give? Just one reason. I want you to apply.
Immunosuppressant.
Just one reason. I just want you to apply. Looking at the condition and looking what I'm saying, glucocorticoids. The condition. There was a question I asked A patient came to my panel and I was asking this question. I was asking this simple question. The patient was bleeding, and I was asking so in your counseling, the patient is on this warfarin. So I was asking the patient, if a patient is on warfarin, what type of toothpaste would you give? The paste that you give. He was looking at me as if I've asked a humorous question. Patient is on warfarin. In your counseling, the toothpaste, what type of toothpaste would you recommend? What type of toothpaste would you recommend? Gilbert. Gilbert, do you have issues or you want to answer? Gilbert.
Sir, please, you advise patients not to use toothpaste that are red in color because the warfarin can cause bleeding, gum bleeding, and if you use that red toothpaste, you wouldn't see the bleeding if it occurs.
Mm-hmm. You are right. You are right. So this is simple application. The same thing. The same thing who can apply. Just determine why we are using this. Why you want to consider glucocorticoid. Oh, this anti-inflammatory activity. When we started in nutritional supplement, we said that there will be malabsorption, and therefore the patient will need it. And the effect of these glucocorticoids would increase. The effect of this glucocorticoid will increase what? Would increase the glucose level. Class, do you get me?
Yes, sir. Doc, please, can you take it again?
Who heard me? Who heard what I said? Steve, you heard me.
Yes, sir.
Can you repeat? Or re-echo what I said?
Okay, so due to the fact that there's malabsorption in the IBD, giving glucocorticoids, we established that glucocorticoids will have the ability to increase the levels of glucose. So some way, somehow, we are sort of providing some form of nutrient to the patient. Yeah, and so that's one reason why we prefer that to the other steroids.
Thank you.
Thanks, Uncle Steve. Thank you.
You're welcome, sir.
I didn't know you are uncle. So we use glucocorticoid.
Doc, I'm not. Doc, I'm not.
You are not. So tell the lady not to call your uncle again. Huh? Can you do that now?
Yes, please.
Do that now. Either than I'll be calling you that.
Um, please, I will tell her after the class.
No, I want to hear. Steve, can you do that now?
Okay. Hello. Please. I'm Steve. Yeah. Thank you.
No. Call that lady. It's not the class, the whole class. Just one person.
Doc, please. I didn't catch her name. Yeah, I
So
don't remember her name. That's why.
So ask.
Benedicta Delasi.
Hi, Bennett. Please, I'm Steve. Yeah,
Bennett, are you around? Bennett, are you around?
Yes, please, I'm here.
Steve is talking to you. So, Steve.
Okay. I'm going to answer like
Hi,
this.
Bennett.
Hi.
All right, thank you.
You're welcome, Uncle.
Steve, you said you Steve, you heard her. You say welcome,
Yes,
Uncle.
thank you.
Okay, so glucocorticoid. So example of this, we have hydrocortisone, we have prednisolone. So these are one of the class of medication among the mainstay medications. Among the mainstay medications for IBD, very important for IBD. So we have those that could be given for parenteral route, oral, and also be given oral, and also be given via NMS or suppository. So it's very important. So these medications are given, and normally steroids, when you are giving steroids and you give it for prolonged period, that is one disadvantage of this. You cannot stop cannot do sudden stoppage. You cannot do that. So you need to taper these medications. You need to taper. Assuming a patient has been on these prednisolone or oral steroids, especially the oral one, how are you going to tell the patient to reduce the regimen or to stop the regimen? Patient has been on these for say 1 year. Patient was on 40, was on 40 milligram per day. How are you going to tell the patient to taper it?
So please, you would taper down. You would taper down every week. So for the 40, you can taper to, I'm not sure, but let's say 35, then you come to the lowest dose.
I'm listening on.
Yes, I would say you taper down weekly.
Mm-hmm. So I'm listening. Weekly. So do it for me.
So please, that's what I know for now.
Oh, so start again.
So I was saying you taper down weekly. So for the 40 milligram, you can do you can taper down to 35, then 30. Yeah, so you get there.
I was reading this tapering. I was reading one of Oxford Hospital, their protocol, and listening to the way they were doing it. I was going through their protocol for IBD patients, and they were doing this. This is their protocol. So the patient has been on 40, so they were tapering it in this way. This is a protocol from Oxford. So they did 40 milligram per day for 1 week. And they came to 30 milligram per day for 1 week. 30 milligram per day for 1 week. Then they came to 20 milligram per day. And for 20 milligram, I don't know, they did for 4 weeks. So they were on 40 for a day for a week, 30 per day for a week. And when it came to half of the dose, 20, they did the 20 milligram per day for 4 weeks. And it came to 15 milligram per day, came to 10 milligram per day for 1 week, 15 milligram per day for 1 week. And it came to 5 milligram per day for a week. Then they stopped. This is the way, but I was wondering why when they got to 20, they did the 20 for 4 weeks. Who can help me with this? Why when they got to half, they gave it for 4 weeks before continuing?
Please, I think to reduce the risk of relapse, especially when you are tapering the dose down, patients might get relapse with the IBD. So they usually, whenever it reaches half the dose, they want to do it for a while to see if the patient doesn't relapse, and then from there they continue to decrease the dose.
So don't assume it's if the patient has been on it for long, don't taper it so steep. Don't do it so steep. So because when you are tapering it, the concentration will be reduced and the risk of relapse could be up. So you calm down a bit, you could stay there for some time. Then so that is that. But another glucocorticoid, another anti-inflammatory agent, which is budesonide. Budesonide is very, very potent. In terms of its affinity for glucocorticoid receptors, it's about 50 to 100 times that of the prednisolone. So it's also effective in the management of IBD under the steroids. So it comes in an oral form, could also be given rectally. Budesonide is very potent in that. So these are classes, general classes of medication are used. You could use metaprednisolone. You can use, when you want to go in with parenteral, you can use hydrocortisone. Then oral, we can do prednisolone. You can do budesonide in managing the IBD. Please, I mean, any question? Okay.
Please, I have a question. Please, when we were talking about the immunosuppressant, Attakorah, you said they can be given for long 5 years. So I wanted to know about the other forms of drugs used in it, say the glucocorticoids. How long should a patient be on it?
Normally, they can also be on it for long time. They could also be on it. That is why we are saying that if a patient is on it for a long time and want to stop it.
No, okay. And I know that some drugs will induce remission. Some too must maintain the remission. So please, which ones will, or any of the ones we've discussed, will maintain remission? Can be used in acute cases too.
These medications used to induce remission in acute effect. And these same medication could be used for acute. Is it, Evan? Where are you? So for this medication, acute, looking at acute as inflammatory activity. So what can I do? Two things. You look at the inflamed area and you look at what is causing it. So in acute, what will I do? Let me tackle the inflamed area. So when you tackle the inflamed area, then you think about tackling what is causing it. It's like, let me ask you this, it's like asthma. When a patient comes with bronchoconstriction, and we have salbutamol, and we have steroids, which one will you give first, and why?
Doc, please, I'll give the salbutamol.
Why will you give salbutamol first?
Doc, please, it has a quick onset and it will relieve the acute exacerbation.
And so to relieve the patient, you are thinking about relieving the patient first. You are not thinking about what is causing it. Something is causing the inflammation. You are not thinking about tackling the inflammation. So this is the way management is for acute relief. You want to think about the inflamed, what is affecting the area, and you think about relieving the patient, then you come again. So in order to maintain the remission, so if you use, assuming you use the mesalazine in acute state, in order to maintain remission, then you'll be thinking about what? These steroids. Now you are looking at what is causing these things. So the first thing is to look to relieve the patient. So look at the drugs that will help the patient. Then the second aspect, to maintain the remission. Then you think about the causes, what is causing it. Then you tackle the causes. Do you get it?
Yes, please, I get it. Thank you very much.
That will be the remission, maintaining. Okay, so it's left of COPD. I will just be touching on the salient points about COPD. And you see whether we can do any other. So learn, or please. Learn your clinical, learn learn the lots, please. And now it's getting to an end. These things will be coming. The anxious will set in. And your mates, some of your mates always will be confusing you. They'll be coming with, I don't know how you people get it. They will come, small thing, they'll be circulating it. Small thing. Then it's more dangerous when you are dealing with such a people. Small thing, then the whole thing will be circulating. Good Samaritans. And then when you see these things, I saw a list, 25, about disease conditions. I don't know who gave it to you. It said you should learn about this. These are the areas coming. So, wow. Have your own program and learn. Don't let anybody put that fear and they come in and saying that hey, this area will come. Then you rush and go and learn. Then somebody will come, this area will come, and you'll be rushing through. Organize yourself and learn. It will work. Okay. I'll see you for COPD.
Hello, sir. Hello.
Listening.
Sir, please, the statement you made about the treatment of acute asthma exacerbation or attack, you mentioned that we give the corticosteroid first instead. I thought it was supposed to be the salbutamol, the short-acting.
Did I tell you, Abigail? These are the things. Did I tell you to give the steroid first?
You said, why don't we treat what is causing the...
Did I say one of your colleagues answered it? And I was asking, why don't we use this first? And I used the same answer for the IBD that he asked. So I didn't say you should use the steroid first. You should open up. There's an acute situation. So you should open up. So you give the salbutamol first. So to maintain the remission, then you give the steroids. I was just using that to explain. I didn't tell you we should use the steroids first. I didn't say that. Abigail, go back. Why?
Yes, please, sir. Thank you.
Bye-bye.
Bye.
Bye.